Hi, Nick here, dialysis nurse. Today I'm going to talk to my hemodialysis nurses and technicians about look, listen, and feel. Now I know we all know what this is, but I'm going to just dive into it in some detail real quick. So if you look at the picture to the right, you'll see a skin rash at the fistula site. And the skin rash could be due to irritation from tape, some allergies to the disinfectant that's used to clean the fistula. It can be inflammation. So we don't know what this is, but we want to make sure we assess it before we access that fistula. Now, if you look at the picture on the left, you'll see two buttonholes. The buttonholes clearly have a lot of redness there. It looks like it's inflammation. It looks like it's a possible infection going on. We don't want to cannulate that site until we're sure of what's happening here. We don't want to cause cellulitis. We don't want to cause an infection going to the patient's bloodstream. If you look at the picture on the left, that is a picture of an aneurysm. Aneurysms happen due to technicians or nurses continuously hitting the patient at the same site on their fistula every time they come in for treatment. They're supposed to use the rope ladder technique so aneurysms don't form in the first place. Aneurysms can also happen due to outflow stenosis, the narrowing of the fistula on the outflow section. Now with aneurysms, we want to make sure we note when the aneurysm first becomes present. We want to note its location and its size. Aneurysms can get very, very big to the point where your skin becomes paper thin and very shiny. That is a bad warning sign of rupture. Make sure if you note this to the doctor immediately. Do not cannulate this site. The patient can lose a limb or lose their life if the aneurysm ruptures. The picture on the right shows a hematoma. Hematomas are usually occurring due to bad cannulation techniques. So if you have a nurse or a technician that's new, make sure to get proper education and training before they're cannulating fistulas on their own. Miscannulation of a fistula can lead to inflammation, hematomas, and loss of access sites. So make sure that if a new nurse or technician is cannulating the fistula, just be there by their side to help guide them. We want to make sure we watch out for Still syndrome. Look for peripheral cyanosis. Still syndrome usually occurs because that new fistula that patient has is taking away too much blood from the patient's hands or fingers. Usually happens in upper arm fistulas, usually happens with patients who have PAD due to diabetes or chronic smoking. So if a patient complains of cold fingers, if you see that the fingers are turning blue or a darker color, if they complain of pain in their hands or in their fingers, off dialysis, and especially while on dialysis, notify your physician, notify your nurse, make sure that you properly assess them for Still syndrome. Stenosis. This usually happens in patients who have multiple CVCs or multiple central venous catheters, or patients who also have had cardiac devices with leads. So central venous stenosis usually shows up as an extremely swollen right side extremity or chest area, as you can see from these pictures, and also collateral veins that appear in your axillary area, your shoulder area, and in your chest area, as you can see from these pictures right here. So when you're assessing a patient, even if they have a fistula and they never had a CVC, if they've had some kind of cardiac device with leads, this can definitely happen, the swelling and the collateral veins. So when you're assessing your patients with fistulas and CVCs, make sure you assess for this. Now, if you don't assess for anything, everyone should at least be able to do this 10-second test to any patient with a fistula. So this patient has an aneurysm in his arm, but regardless, this 10-second test works the same. Raise his hand completely up, vertical, and the blood will leave that area. The fistula will collapse. It takes a little bit longer for the aneurysm to collapse, but not that much longer. If collapsing does not happen, that is a sign of stenosis. Now, as they lower his arm back down horizontally, the blood returns, the fistula becomes distended again, and that's a clear sign that his fistula should be working properly. So that was look. Now we're going to go to feel. We're going to show you some ways you can feel the fistula to see if you can notice any signs and symptoms of stenosis or occlusions. Now, fistulas don't usually pulse. If they pulse like this, that's a sign of stenosis. Fistulas usually kind of vibrate, what we call a thrill. Now, I'm going to show you this augmentation test that we do to see if there is stenosis in the fistula. So the augmentation test, I'm basically going to press down on an area a few centimeters from the anastomosis. So I'm stopping the thrill, and when I do that, it becomes hyperpulsatile. So that's going to be a very fast pulse, pulse, pulse. So this is a good sign. It should be doing this when you compress that area. Now here's another example with inflow stenosis. You're pressing down on an area a few centimeters from the anastomosis, but you have a very weak pulse. That's a sign that you have stenosis in the inflow area. There should be no thrill there at all. If you look at it side by side, picture on the left, you stop the thrill, it becomes hyperpulsatile. Picture on the right, you stop the thrill, it becomes very weakly pulsatile, indicating inflow stenosis at that anastomosis area. Okay, so just an FYI, with outflow venous stenosis, what we're looking at now, an aneurysm can form. So poor cannulation techniques can form aneurysms in patients, and also outflow venous stenosis. Now, this first clip shows a continuous thrill. It was a normal clip, nothing abnormal at all going on in that picture. Now, in the second one, you have outflow stenosis right here. So if you look at the area distal to the stenosis, you would see it pulsing. There's no thrill there. It's just a hyper pulsing that's occurring right there. If you look at it side by side, you'll see normal outflow with a thrill, and then you'll see outflow stenosis where the fistula becomes pulsatile, firm, and loses the thrill. Now, also, if you do an arm elevation test, there will be no collapsing of the fistula. Now, you're going to also look to see if the fistula is hyperpulsatile. So with a normal fistula, you'll just have the regular thrill as indicated by this video right here. There's continuous thrill on the outflow tract. Nothing abnormal is going on here. But in the second video, you'll see with the stenosis, distal to the stenosis segment of the fistula, you'll see a hyperpulsatile action right here. So the thrill is absolutely gone at this area. And you just have this hyper pulse area right here. So that's something key to note when you're assessing your patients. This is without you pressing your finger down on the fistula. This is just how the fistula is behaving normally. So if you look at the pictures side by side, with outflow venous stenosis, you'll have this hyper pulsatile area distal to the stenosis. Absent of the thrill, you will not have a thrill. Arm elevation, it will not collapse. So we're going to talk about accessory veins next. Now, when a patient has a fistula, especially a new fistula, this test should be performed. So you remember the augmentation test? When you press down on the fistula, that thrill stops and there's a hyper pulsating area right next to your fingers or distal to your the stenosis that you created. Like this right here, this animation shows. This is normal. You press down, the thrill should leave, and a hyperpulsating area should appear. Now, what if you press down and that thrill continued? Now, if that happens, then the patient may have formed an accessory vein. This isn't a good thing. Accessory veins can prevent the maturation of a fistula. It can lead to loss of pressure to that main channel, that main outflow tract, because there's another channel that formed. So if the thrill does not disappear, then the patient may have an accessory vein. Definitely tell the doctor about this. If the thrill does disappear, then the patient's good to go. But this is something that you should pay close attention to when your patient has a brand new fistula. So sleeves up for AV grafts. So grafts are not open forever. So if a patient has a graft on their forearm, every now and then look at their bicep area to see if the veins are getting larger and larger. If they are, that is a great sign that they may be ready for a fistula, or if their graft fails, they have an area suitable for a fistula. So if your patient has a forearm graft, look at that bicep area, see if the veins are maturing, let your doctor know. Now we're on our listening segment. We're going to listen to the anastomoses and the cannulation site. You can listen all the way up the arm, but the sound is very loud at the anastomoses and cannulation site. So this is what it sounds like with no stenosis when you're listening with your stethoscope. And now this is what it sounds like if you have stenosis or blockage. And that's it. That's my look, listen, and feel segment. More mistakes are made by not properly assessing your patients. This takes 10 minutes. Let's do the right thing. Take care. Ciao.